All right, thanks so much for coming out for our third CHEP seminar of the semester. Just a reminder that there will be no seminar next week, so you can recharge your batteries for the talk the following week. But this week we're really fortunate to have Corey White visiting us from Cal Poly San Luis Obispo. Corey is trained as a labor economist and as a health economist and has already published in the top field journals in the Journal of Public Economics and Labor Economics. And today he's here visiting CHEPS to present his work on the social and externality benefits of the influenza vaccination. Thanks so much for coming.
Thanks, Joe. And thanks everybody for having me. It's been great to meet a bunch of you today. Really great departments here. Really enjoyed my visit. So I guess that's my cue to start. Okay, so the goal of this paper is right there in the title, measuring social and externality benefits of influenza vaccination. I'm going to be doing this in two different settings. So in the first setting, I'm going to be thinking about vaccination in the general population. So the idea here is I'm going to be using differences in state-level vaccination rates interacted with annual variation in how effective the influenza vaccine is. All right, and the idea is I'm going to try to relate state-level vaccination rates to outcomes observed at the state level. All right, so by taking this kind of aggregate approach at the state level, I'm going to be able to pick up any externalities that occur within a state. All right, so I'm trying to kind of get at the social benefits, at least at the state level. Okay, and then I'm going to be looking at mortality and work absences. In the second component of the paper, I'm going to take a particular focus on a group with high potential externality benefits of vaccination, that's healthcare workers. Right there, it's going to be a completely different identification strategy. And it's going to be kind of like a policy experiment exploiting the rollout of healthcare worker vaccination mandates in California. Okay? There, I'm going to be looking at essentially outcomes like the health of their patients. So using data on hospitalizations and emergency department visits, looking at diagnoses for influenza in the hospital. Right? Before getting to all of that, a couple kind of statistics on influenza in general. So these are just some kind of standard numbers from the CDC. So first, influenza affects a large number of people, all right, somewhere between 5 and 20% of the population each year, all right, extremely widespread. Those infections result in, on average, about 200,000 hospitalizations in the US, all right, those are inpatient hospital admissions, and about 23,000 deaths, all right. What I want to underscore here is that influenza is a lot more severe than most people think it is, right. A lot of people actually die as a result of influenza infection. A note on especially deaths, these are estimates. So there's other estimates out there that indicate that influenza-related deaths might actually be much higher, so closer to 50,000 deaths per year. Okay?
Oh my gosh.
Influenza also affects everyone, right? There's nobody that's completely immune from influenza. Most of the literature in economics has focused on the in utero population, right? There's the classic paper by Doug Allman in 2006 on the 1919 influenza pandemic, looking at the effects of in utero exposure to pandemic influenza on adult labor market outcomes. There's been some more recent work on non-pandemic influenza, so seasonal influenza, like the paper by Hannah Schwant, kind of doing the same thing, looking at seasonal influenza and adult labor market outcomes. All right, I'm going to focus on the out of utero population, so children, adults, and the elderly. So I think it's useful to think about how each of these groups might be affected by influenza infection, thinking about the outcomes I'm going to be looking at going forward. All right, so for children, influenza infection can be relatively severe, often resulting in hospitalizations, also a lot of outpatient visits, although mortality is relatively rare, although not completely unheard of, obviously. Right? In non-elderly adults, this is where influenza infection is, I guess, the most benign. Right, but these infections still result in a lot of outpatient visits and work absences. All right, but mortality and hospitalizations are relatively rare compared to children and the elderly. All right, the elderly population is where we expect influenza infection to be most severe. Hospitalizations are very common, and most of the mortality burden from influenza is in the 65 and older population. All right, so the CDC estimate is that about 90% of all influenza-related deaths is in the 65 and older population. My definition of elderly is going to be a little bit different than this, though. 75 and older. Okay, so that's all kind of bad news so far. Good news, of course, is that influenza is a vaccine-preventable disease. I think I wouldn't be a very good economist if I focused on the good news, though. So the bad news again is that vaccination rates for influenza are relatively low compared to other vaccine-preventable diseases. All right, so if we compare influenza and the measles and mumps and rubella vaccine, in 2013 in the US, vaccination rate for influenza was about 43%. The MMR vaccination rate was about 92%. Right? One big obvious reason for this is that the cost of, that annual vaccination is required to maintain immunity against influenza. The way I like to think about this is that the cost of influenza vaccination is relatively high compared to these other vaccinations where you can get it once and it'll confer long-lasting, if not lifetime immunity. And one other kind of note on this, actually let me just bring this up. I presented this paper a couple times in Europe recently, and I like to show this figure because it demonstrates the US superiority to every European country in terms of influenza vaccination. This is really a rarity in terms of like provision of public health goods. But yeah, the US actually has the second highest vaccination rate of any country in the world behind Japan, right? So higher than any other European country. So one thing I'd like to emphasize is there's a lot of room for improvement with influenza vaccination rates, right? And that's not just in the US, but in every country, even, Sweden and Norway. Okay, so what does this high cost of vaccination mean? Let me say, by the way, questions are always welcome. I feel like I've been doing a lot of talking, so if you have any questions, let me know. So what does this high cost of vaccination mean? Well, the vaccination problem that we think about as economists is still very much relevant for influenza, where it's a little less relevant for diseases where the vaccination rate is kind of near 100%, or at least at kind of maximum, given that some portion of the population has contraindications for the vaccine. All right. So what's the problem? The vaccination problem? Well, it's the simple idea: vaccines are good with a positive externality. Benefits are not fully internalized by the recipient of the vaccine, so the good is going to be underprovided relative to the social optimum. All right. Here is my, Econ 101. I show almost exactly the same figure to my survey of economics class for non-majors. I'll show you why I'm showing you this in just a second. I think everybody kind of understands what's going on here. But there's some marginal private cost of vaccination, right? There's a marginal private benefit. The competitive equilibrium vaccination rate is where those two things cross. That's VE here. Where the marginal social benefit crosses the marginal private cost is the socially optimal level of vaccination, right? I'm interested in measuring the height of the marginal social benefit curve, and in some circumstances I'm going to try to actually measure the size of the externality. Okay? What this is useful for is kind of leading on to the next slide, where we know essentially that this is not what the social cost curves are going to look like, right? They're not going to be these linear downward sloping curves, all right? So what might the actual shape of these marginal benefit curves look like, all right? So this is not something I did in my paper, but this is a result taken from this paper by Brian Bouillet and co-authors. What they do in this paper is combine this kind of very basic theory of externalities with a kind of standard epidemiological model of disease dynamics, so the SIR model, if anybody's familiar with that, parameterize the model to the case of influenza and try to trace out these marginal benefit curves. All right? So we see kind of an interesting shape for the MSB up here, which is the marginal social benefit curve. All right? What you can see is that the marginal social benefit is expected to be relatively flat until a certain level of vaccination. All right, then it essentially falls off a cliff. All right, so what is that cliff? Essentially this threshold level of vaccination here. So that's what you think of as like herd immunity. That's when enough of the population has been vaccinated that the epidemic actually fails to emerge. So there's no essentially private or social benefits of vaccination because there's no disease to prevent anymore. Okay? What's important to notice is that before this curve is before this threshold, this curve is relatively flat, and we know we're not beyond the threshold because we do experience an influenza epidemic every year, right? So we should expect that kind of in the current state of the world, we're somewhere on this portion of the curve. And just to kind of reiterate the goal of this analysis, I'm again going to be trying to estimate in terms of a couple different outcomes, essentially the height of this curve and the difference between the private and the social curve where I can.
Is there evidence that, this is a little bit of a tangential question, but is there evidence that behavior in terms of getting a vaccination has been responsive to technological changes in the development of other drugs that suppress some of the symptoms of the flu and so on?
So I have no idea. I have not seen any papers on it. So what technologies are you thinking of?
Oh, I'm just...
So thinking like cough and cold medicine.
Yeah, that's right. That's right.
I haven't seen anything like that. I mean, I don't know that there's not. That's a good question though.
Trying to find a way to look for moral hazard in the
that's right.
vaccinations.
Yeah. Okay, so I'm not going to claim that I'm the only paper to try to estimate the benefits of influenza vaccination, right? Basically all this literature, except for one important exception, is in kind of the medical or public health literature. I'm not going to try to cite every paper that's ever tried to do this, so I'm going to try to just kind of summarize the state of this literature on one single slide. Okay, so we can basically roughly break this literature into two components, right? The RCT literature and then the observational literature. All right, so first thinking about the RCT literature. In a traditional randomized controlled trial, you're going to randomize treatment, so randomize vaccination across individuals within a group. You then compare outcomes across those individuals. With a traditional RCT, you can't actually pick up externality effects at all, right? In fact, your estimates would be downward biased if there are externalities present. Right? You can pick up externalities in what's called a cluster RCT, where you randomize across groups rather than across individuals. I think maybe the nicest example of a paper like this is this paper by Loeb and co-authors. This is in the New England Journal of Medicine in 2010. What they do is essentially take these isolated communities in northern Canada, randomize across communities. They vaccinate children in the treated communities against influenza. They vaccinate children in the control communities with, I think it was the hepatitis C vaccination, right? So not influenza. And what they find is that adults in the treated communities had lower rates of influenza, right? So they're identifying this externality, right? What they can't identify is the effects of externality effects or social effects of vaccination for more severe and economically important outcomes, something like mortality or even work absences. So you need kind of implausibly large samples to be able to identify these downstream outcomes that we actually really care about. Okay? There's also the kind of ethical concern over providing placebo vaccinations to high-risk groups. So you actually can't run really an RCT on the elderly population in the US because they're a high-risk group for influenza, so you can't essentially deny them an influenza vaccination, which would be putting them in the control group. So that's another kind of obstacle that you need to overcome with observational data. All right? So what's the state of the observational literature look like? So just to pull a quote from a recent Cochrane review on the topic. So this is on a review on the benefits of the mortality benefits of influenza in the elderly population. What this review notes is that a large number of studies, a surprisingly large number of studies, find implausibly large benefits of influenza vaccination for the elderly population. Right? And essentially the conclusion of this review was that much of the evidence is quite poor quality and due to, quote, systematic differences between intervention and control arms, right? Endogeneity. Right, so there's one paper, to my knowledge, that really does effectively circumvent this endogeneity issue. And I'm going to be building off this paper. It's a paper by Courtney Ward in 2014. What she's going to do is use a kind of identification strategy similar to what I'm going to be doing. Right, she's going to use variation in how effective the influenza vaccination is. Right, and she's going to use this to look at the effects of an influenza vaccination campaign in Ontario, Canada. Okay? What she finds is that this campaign increased vaccination rates by about 10.8 percentage points, and that led to a near elimination of influenza infection. Right? Now, the problem is it's not likely that this is kind of externally valid. I mean, I think this is a really well-executed study, but it maybe is specific to that particular location or those particular years. And the reason I say that is because the post-policy vaccination rate in Ontario, Canada was about 33%. If you remember, vaccination rate in the US is about 43% right now, and we do not have zero influenza, right? So it's unlikely that these kind of effects are going to generalize to kind of the average setting in the US. All right, so the strategy that I'm going to be using, the I think main advantage that I have, is that I'm going to be able to exploit not variation in just kind of one province in a couple of years. I'm going to be able to exploit variation across all 50 states in the United States and across 22 influenza seasons.
So on that note, is much known about kind of the relationship between climate and influenza? Is there, can we say that at higher latitudes it's less likely to spread? Is it something about kind of the way it's transmitted?
So latitude, I don't know how you get exogenous variation in latitude, but so weather, yeah, certainly cold weather and low humidity really encourage, especially low humidity. So really dry weather really encourages the spread of influenza. So
Encourages the spread.
Encourages the spread.
Okay.
Yeah. So you're going to see highest levels of influenza in places that are cold and dry.
Okay.
So Montana, a lot of influenza in Montana, right? I'll show you. I think I'll show you a map of influenza mortality rates, influenza and pneumonia mortality rates.
Gotcha.
You'll see they're going to be concentrated in relatively cold and dry places.
And are we going to be able to kind of take that into account in terms of the social benefits you're estimating? The fact that you're going to have different states with very different climates, that are probably going to have very different baseline vaccination rates, and that for a given, if everyone had the same baseline vaccination rate, the social benefit would presumably be larger in the places like Montana.
Yeah, so
I mean, I know you'll have fixed effects in there and all that, but
right, and controls for weather and stuff like that. I do have to make the assumption, though. I mean, I have to make the assumption that essentially the effect of increasing vaccination rates is going to be common across states. I mean, it's a strong assumption.
sure.
So in some ways, I can let I'm not going to show you this, but deep in the appendix somewhere, I can allow the effect of vaccination to depend on the vaccination rate, right, which is somewhat getting at that. I actually find no evidence of nonlinearity, so it's pretty flat across the observed distribution of vaccination rates. I mean, it's noisy.
Sure.
So I can't really say that there's no nonlinearity, but I don't find any evidence of it.
Okay.
I mean, that sort of is contingent on you being on the flat part of the.
Yeah, so well, you can imagine a couple of things going on, right? So maybe, let's assume this actually is flat during in this region. Then you'd expect to find something that's flat. But as Ryan pointed out, you might expect nonlinearity for other reasons, right?
Yeah, like if you have some states that are closer to the sort of cliff, then you would not have.
You not have nearly as much of a.
Yeah, your identifying assumptions would kind of break down there.
It would be downward bias though. So if you're closer to the cliff and you increase your vaccination rate, the benefit you get from increasing that vaccination rate is going to be smaller than it would be otherwise. Right. So what I'd be identifying is kind of a lower bound effect there. Right.
So that wouldn't be an issue. But if you're looking at across the vaccination rate, then that's not an issue for this, right? It's just a question of is the observed vaccination rate a function of the marginal benefit of vaccination due to state specific?
So yeah, I mean it absolutely is, right? Let me maybe get back to that when I talk about the identification.
We're doing the economist thing of discussing the findings.
Let's talk about this after dinner over drinks or something.
There we go.
So I'm actually not a card-carrying economist. I'm an epidemiologist. So I'm interested in looking at this from a slightly different lens. But I guess I'm not sure if I'm going to ask the same question Ryan just asked. But I tend to think the holy grail of influenza is sort of predicting the seasonal onset, right? The timing of, and so of course that onset of that seasonality that changes from year to year, and it changes from location to location. Probably most of that variation by location is because we say, well, different temperatures, different humidity, different social patterning. But I'm wondering to what degree. I mean, is that just a matter of again putting in when you're going to show us kind of a random effect across time and space, or because I guess and maybe I kind of get lost in the economics verbiage, but to what degree that seasonal initiation is I put it this way: I'm not going to conduct a vaccination campaign in Canada and in Florida starting that same day because seasons don't start that same day.
Yeah, so I mean. So I'll get back to this when I discuss. Yeah, so I think I'll get back to this when I discuss the identification strategy. Basically, the key source of identifying variation is not differences in vaccination rates, right? It's differences in how effective the vaccine is across years. So if that is unrelated to, I mean, it really in some sense can't be related to like local climates, right? Because I'm going to be using one single measure of how effective the vaccine is, and that's going to be common across all. I'm going to define that as common across all states. So it can't really be related to differences across states in like local climates. But let me get back to that in a few slides, if that's okay. Okay. So what are the contributions here? Again, this is going to be broken up into two components, right? I'm going to call these the general analysis and the targeted analysis. In the first component here, I'm measuring the impacts of increasing population level vaccination rates. Again, I'll talk a little bit more about this natural experiment in just a second, but I argue that these provide the first causal estimates of the impacts of population level vaccination rates on mortality and work absences in the US, or any outcome in the US. Right? In the targeted analysis, right, again focusing on vaccination for healthcare workers, I'm going to use this policy experiment exploring the rollout of county level influenza vaccination mandates over time. This is going to represent, to the best of my knowledge, the first large-scale analysis of healthcare worker vaccination mandates. Okay? So a quick preview of the findings in case I don't have time to get to something. In the general analysis, I'm going to find that increasing the vaccination rate by 1 percentage point is going to result in a decrease in mortality by about 0.25 per 100,000 population, an increase in hours worked of about 4,700 hours per 100,000 population. So if we think about this in terms of the size of the US population, let's suppose we increase vaccination by 1 percentage point throughout the US, that'd be about 800 fewer deaths and about 15 million hours gained, hours of work gained. All right, thinking about this in terms of kind of monetary benefits, using a value of statistical life, I'll talk about some of those assumptions later. Each vaccine confers benefits of about $64 in terms of mortality, about $98 in terms of reduced work hours lost, increased work hours. All right. Finally, to try to get at the externality here, which I can kind of do with the mortality, because I'm going to find that actually the mortality benefits are concentrated in the population of individuals 75 and older, I'm going to actually find that this effect is driven by the vaccination of people under 75. Okay? So the effect of under 75 vaccination on over 75 mortality represents kind of a pure externality effect. So these reductions in mortality are going to be driven by, operate mostly through an externality effect, although the estimates will be somewhat noisy. All right, so in the targeted analysis, I'm going to find that healthcare worker vaccination mandates lead to about a 10 percentage point increase in hospital worker vaccination rates, about a 20% decrease in influenza diagnoses for inpatient admissions, and about an 8% decrease in influenza diagnoses for outpatient emergency department visits. Okay? Again, I'm going to kind of do a back-of-the-envelope calculation here, and I find, in terms of hospital costs, each vaccine confers benefits of about $130.
I know the point of your paper isn't to estimate costs, but in the literature, are there any estimates of kind of like the marginal cost of vaccination like that? I mean, I'm guessing there are a lot.
I'm going to have to really leave you in suspense, because that's not till the conclusion. But I'll get there.
All right.
Assuming you stay that long. Okay, so I'm going to go into these two components of the paper one by one. All right, so starting with the general analysis, then we'll move on to the targeted analysis. Okay, so world's simplest empirical equation here. On the left here, I'm going to mostly be talking about mortality, but I'm also going to look at work absences as well. So let's suppose that Y, SMY is the mortality rate, influenza and pneumonia mortality rate in state S, month M in year Y. Could also be the percentage of workers absent for illness. And on the right is the vaccination rate in a given state in year. All right? I could estimate this equation. Obviously, the problem is that vaccination rates at the state level are likely to be endogenous. Right? And we can see that pretty easily if we just show you a figure of influenza vaccination rates and the pneumonia and influenza mortality rate. All right, so this is kind of a proxy for influenza-related mortality. Okay, if you just kind of blur your eyes, you can note kind of a positive relationship between these two variables. And if you estimate that kind of naive regression on the previous page, you do indeed find a positive and significant coefficient, right? That would say more vaccination leads to more influenza-related mortality, which we don't think is likely to be the case. All right, so if I want to get at this causal effect, I need some variation, plausibly exogenous variation in influenza vaccination. All right? So to kind of describe my identification strategy, I'm going to use this figure. So let's first focus on the top panel here. So I have 3 different influenza seasons here. The 96-97 season through the 98-99 season. I have the actual vaccination rate in 2 groups of states here. So the blue is a group of 5 states with relatively high vaccination rates. So they're the 5 states with the highest average vaccination rate over time. The pink dot is a group of relatively low vaccination states. So the lowest 5. All right. Now what you can see is vaccination rates evolve smoothly over time. And importantly, the gap in vaccination rates between these 2 groups of states evolves smoothly over time as well. Okay? Now what's not smooth over time is the match rate. So those little X's represent the vaccine match rate. So that's the degree to which the strains chosen for inclusion in the vaccine match the strains that end up circulating in the influenza season. Okay? So in the first season, the match was close to 100%. Second season, the match was about 15%. Third season, the match was close to 100% again. Okay? So I'm going to define effective vaccination as just the product of actual vaccination rate and the match rate. All right, if I do that, we can look down at the second panel here. What we see is that when the match rate is high, that difference in vaccination rates between these 2 groups of states is preserved. Right? When the match rate is low, there's essentially no difference between these 2 groups of states in effective vaccination. Right? So the strategy here is essentially going to be to compare relatively high vaccination states with relatively low vaccination states in years with a highly effective vaccine versus that same difference in years where the vaccine is not very effective.
So is there a difference in the match rate across the states?
Is
there a variation in the match rate across states?
So the way I define it, there's not going to be. There can be conceptually, certainly. I actually don't find in my sample that there's a whole lot of difference. There's a whole lot of variation across states within a given year of the match rate, though. But the way I'm going to define it is going to be common across states.
So it's based on the data from the entire country? Yes.
So for the whole sample, I actually can only define it as nationally. For part of the sample, I could define it as region-specific. If I just take that part of the sample, it's very similar results. But yeah, for the main analysis, it's going to be defined as common across all states.
Yeah.
So, so you've got 3 seasons here, and it looks like there's almost no relationship between the match rate and actual vaccinations. Is that true across?
Yeah, so I'll show you a regression of that in just a second.
That seems so surprising because, so often you hear, oh, it's going to be bad flu season, and it's going to be so bad because the vaccine isn't a good match this year. There's information leakage.
So, let me get back to that in just a second. I'm going to talk a lot about that.
All right.
Can you tell me, I'm sorry, I'm one of the bad 57% that doesn't vaccinate. So what, just tell me something about the medically, sort of about how good they are sort of at predicting the particular strain and how widely, tell me.
Yeah, so I will, I hopefully, if you still have these questions in 5 minutes, get back to me. Did you have a question?
It's all related to the stuff that you're about to tell us.
Okay. So this is basically a diff and diff strategy. All right. So the equation I'm going to estimate is going to look something like this, right? What I'm interested in is the interaction between vaccination rates and match rates. All right. It's a diff and diff, so the identifying assumption is essentially just a parallel trends assumption. One complication here, of course, is that it's possible for individuals to respond to the match rate in terms of vaccination behavior. Okay. I'm going to argue, in one more slide especially, that this is relatively unlikely in this setting. All right. Furthermore, for this to be a problem for identification, it has to be that there are differential responses across high and low vaccination states to kind of induce bias in the estimates. All right. I can also explicitly account for this by only using pre-existing variation in state-level vaccination rates by essentially just instrumenting for current season vaccination with vaccination rates in that state in prior seasons. All right, so I'm going to show you for each kind of regression I run, different specifications where I'm going to, in some specifications, do this instrumental variable strategy where I'm going to be instrumenting for current season vaccination with vaccination in a prior season, so that vaccination should not be determined at all by current conditions. Okay.
Sorry, the logic for that instrument is just that there's habit if I got vaccinated last year, then I'm probably going to get vaccinated this year. Is that?
Yeah, so if you live in a state, if you're the type of person that lives in, say, California, which has a relatively low vaccination rate, you're going to be relatively not as likely to get vaccinated as somebody else in a higher vaccination state in each year.
Okay.
Right. The logic is essentially that I don't want my vaccination rate to be determined by current conditions at all. So by instrumenting for vaccination rate with vaccination rate previously, which is essentially determined by kind of habit formation, I can kind of sidestep that.
And so,
But
have you done the... Sorry, go ahead.
I was going to say the extent to which current vaccination uptake responds to contemporaneous matching, I don't think that you're necessarily instrumenting for that. In that, if there's information leakage and people get vaccinated when they expect it to be more effective, I don't think lagged vaccination rates adequately accounts for that. Does it?
Well, so the idea with the instrument is that the only variation in vaccination I'm using comes from this kind of habit formation argument, where the fact that you're the type of person that's more likely to be vaccinated anyways, right? So it shouldn't be responding to current season condition.
Okay.
So let me talk a little bit about match rates, okay? So, another kind of key assumption here is the exogeneity of match rates themselves, right? So kind of understanding this requires understanding how kind of a vaccine mismatch occurs. All right, so this process is going to start in kind of early spring, so in March or April. The World Health Organization is going to get together. This is going to be at the end of a particular influenza season, but they're going to be determining the vaccine for the following influenza season, which is going to start about 8 months later. Okay? They're going to make recommendations as to the kind of formulation of the vaccine. Shortly after the WHO gets together, the FDA gets together in the US and decides on the final formulation for the US vaccine for the next influenza season. This typically happens in April. All right, so again, they're deciding this in April for the influenza season that's going to start 8 months later. Okay, they decide on either 3 or 4 strains that are going to be included in the vaccine. 4 more recently with the quadrivalent vaccine, 3 before that. That was 2012 when the quadrivalent vaccine was developed. So what's going to happen between April and the following influenza season? All right. So when we get a mismatch, that's a result of essentially genetic mutation in the virus. So there's always some level of influenza circulating in the population, right? Even if we're not in an epidemic period where there's lots of people infected, there's always some number of people infected in the population. So I think I discussed this with the master's students earlier. And I mentioned there's probably a few people in the city of San Diego affected with influenza right now, right? So a new strain kind of occurs when these viruses undergo genetic mutations called antigenic drift, and it's essentially random genetic mutations in the virus. So you're going to have a vaccine mismatch when one of those mismatched strains, so these strains that mutate enough to be genetically distinct from the strains that were included in the vaccine, kind of becomes one of the dominant strains in the next influenza season. Okay? So what else is happening between April and, say, January when the influenza season begins? So the reason they have to do this in April, decide on the formulation for the vaccine, is because it takes a while to manufacture and distribute these vaccines. All right, so the manufacturing process begins shortly after April. The distribution process begins in August. So has anybody actually gotten their influenza vaccination already? Good job. I haven't. It's pretty early right now, but most people get vaccinated in October or November. Okay? Then when does information come out about the actual effectiveness of the vaccine? Well, not really until there's an epidemic starting to form. All right? So you need a significant number of people actually infected with influenza to be able to say anything really with any confidence about how effective the vaccine is going to be that year. Right? Because you might have a couple people that are infected with a non-matched strain, but that doesn't mean you're going to have a really poor match for the entire influenza season. So it's not really until December or January, when significant numbers of people are being infected, that you really have a lot of information about the vaccine match. And by that time, almost everybody that's been vaccinated has already been vaccinated. All right? Yeah.
Has there been any sort of temporal variation in, again, I'm thinking sort of technological change that allows us to sort of shorten the period between when we have to make the production decisions about this sort of new vaccine and when the start of the season happens?
So as far as I know, in the last 20 years, there's not been any real change in when they've started the kind of manufacturing
It's always
process.
April.
So if you take like H1, 2009, the H1N1 season, there was a big push to get the vaccine for the H1N1 virus manufactured really quickly. But that was exceptional, right? So I think technologically they might be able to do it, but the way the systems are in place right now, and the way they've been doing it for the last like 20 years or so, the manufacturing process starts in about April.
I can make just a quick comment just to address that too. So, and it's not to be too technical, but the flu virus has two types of proteins. We hear about like H1N1, and so the H is the external kind of protein that mutates a lot, and that's what the hemagglutinin, and that's what our vaccines always target. And the core, which is the neuraminidase, the N, is also can mutate, but much more slowly. And for various kind of reasons around complexity, we've never successfully targeted a vaccine. I'm going to enter this, but to that core. And people are actively working on that, and I think there's a shift in thinking, and I think that would change that mismatch.
Yeah, I mean, so that's the idea of the kind of universal vaccine, right? So I think the benefits that I estimate in this paper could actually speak to the benefit of a universal vaccine as well, which would be huge, obviously. So I could not have explained that nearly as... Thank you. Okay, so quick information about the timing of influenza activity versus vaccination. So pink here is average influenza activity across all the seasons of the sample. What you can see is November, on average, there's a little bit of influenza activity. December, January, February is where it really picks up. Here's the cumulative vaccination rate across the season. So what you can see is lots of people get vaccinated in October, or by October, and almost everybody by November. Right? So by the time influenza season is really hitting, almost everybody that's been vaccinated, or is going to be vaccinated, has already been vaccinated. Right? So I'm not going to claim that there's no scope for people to respond in terms of vaccination behavior, but there's little scope. Okay? So I think maybe a little bit more convincing than that is if I just run a regression of vaccination rate on the match rate, right? What I'm going to find is a small and insignificant coefficient. So this would say that increasing the match rate from 0% to 100% would decrease the vaccination rate by about 0.13 percentage points. Right, so really small number there. And then if I test for differential responses to the vaccination rate by interacting with the mean vaccination rate across or the state level mean vaccination rate, I find there's no evidence of differential responses to the match rate across high and low vaccination states. Okay, so if all of that is still unconvincing, I think to me actually the most convincing evidence that these represent kind of causal estimates here come through a whole bunch of robustness checks and falsification tests. Okay, I'm going to show you a few of those. One of them is actually going to be kind of explicitly built into the estimating strategy. All right, this is going to use the idea that we should not expect any causal effects of influenza vaccination if there's no influenza circulating. Okay, so what I'm going to do is just interact essentially the right-hand side of this model with a measure of average influenza activity across months. All right. So my main estimation strategy is going to look something like this. Right, I'm going to be interested in this triple difference here. Right, notice that influenza activity is defined only at the monthly level. It's going to be scaled from 0 to 1. 1 is going to be the month with the highest average influenza activity. That's February. All right, so 1 represents February. July is 0.05, and that's the lowest month. Okay. These coefficients do not have a very nice interpretation. I'm mostly interested in Phi1 and Phi2 here. Phi2 essentially represents the causal effect of vaccination when there's no influenza circulating. Okay? I'm going to provide some kind of interpretations of these estimates as we go through the data.
Sorry, I have a question.
Sure.
Can you go back one slide? What is this delta SM?
So, sorry, these are month by year and state by month fixed effects.
State by month.
Yeah. So this is allowing seasonality to vary by state level. So I'm going to show you for each model that I estimate, I can actually show you 3 different specifications. One is not even going to include state fixed effects at all, right? This estimation strategy doesn't even rely on state fixed effects, right? Because I'm actually just able to control for the actual level of vaccination. Okay, so I'll show you without state fixed effects, with state by month fixed effects, and then with state by month fixed effects plus the IV strategy. All right, so those will be the three specifications I showed you. Okay, so a little bit about the data. I just want to make a few notes before we jump into the analysis here. All right, so what's the sample? 1993 to 2016. From here on out, a year is going to mean July to June. Okay, so like I call them flu years. That way I'm capturing essentially the entirety of influenza season. Okay, so my main outcome here is going to be mortality from the National Vital Statistics System. The outcome is going to be the pneumonia and influenza mortality rate. Influenza on its own is really rarely classified as a cause of death in the vital statistics. So you get a huge underestimate of the amount of influenza mortality if you just use influenza-specific mortality. So here I'm using the kind of next level of aggregation up, pneumonia and influenza mortality. Okay? Vaccination rates are going to come from the BARFIS. I'm sure a lot of people here are familiar with the BARFIS, Behavioral Risk Factor Surveillance System. I'm going to scale state year vaccination rates from 0 to 100, so we're going to interpret this as a 1 percentage point increase in vaccination rates. Match rates coming from the CDC. In fact, all of this is from the CDC in some way. Match rates are going to come from the CDC. It's the percentage of strains, circulating strains that are included in that season's vaccine. Scaled from 0 to 1, so we're going to compare a 0 match season, which actually is not observed in the sample, but the lowest I observed is about a 15% match, to a perfectly matched season. We observed actually a couple, at least with the data I have, perfectly matched seasons.
And you'll show us the distribution sort of across seasons, or can you describe it to us just to...
It's in the paper.
Okay.
So a figure 2 or 3 in the paper, so I don't have it in the presentation.
That's
fine. Influenza activity also going to come from the CDC, and then I'm going to include weather control, so temperature and humidity, etc. Okay. Yeah.
Is there any seasonality in the deaths?
Oh, absolutely. Yeah. So there's a lot of seasonality in pneumonia and influenza mortality.
So which months do they primarily occur?
So peaking during influenza season. So peaking in the winter, and the trough is in the summer for the outcome I'm looking at here.
So you have a lot of deaths, like November, December, and then basically the vaccination rates are
So the
2
vaccination
months before.
the vaccination rates are going to be defined at the annual level. All right. So I only observe vaccination. Well, yeah, I pretty much only observe vaccination rate at the annual level. So that's only going to be defined annually. There is seasonality in mortality. Much of that should be pulled out with both the year by month and the state by month fixed effects, though. The seasonality that's not due to the variation I'm explaining here.
Yeah. No, I was just thinking of people reacting to the number of deaths. If they said, I don't know, 5,000 people died in California last year out of influenza, I'd go like, oh, rats. I mean, I better vaccinate this year.
So I will say also that
I would react to those news much more probably than the match rate, just because it would scare me way more. So that's what I had in mind because of that. I was just trying to think of whether people react to those news probably more than to the fact that there is a match rate, because it scares me more. What is at stake is way more.
So I'll think about that. I mean, one thing I would say is the outcome I'm using here is much more broad than influenza deaths. So I think the number of deaths in the pneumonia and influenza category is at least 10 times higher than just pure influenza deaths. So in some sense, the actual deaths I'm picking up out of this are a relatively small proportion of the total number of deaths that is defined by this outcome. But I need to think about that more. It's a good comment.
No, I was trying to think about it at the same time. Yeah.
Okay. So as I mentioned, 3 columns here. What I have till 45 after. Is that right? Okay. 3 columns here. The first one, no state fixed effects at all. Second one adds in state by month fixed effects. Third one uses the IV. Okay. In panel 1, I'm looking at the outcomes in the PI mortality rate, pneumonia and influenza mortality rate per 100,000 population. Panel B is going to be the percentage of workers absent from illness. This data is just from the current population survey. Okay? All defined at the state, year, and month level. Okay? So the first coefficient I want to focus on, and this is really what I consider my main specification here, column 2, no instrument, but having those state fixed effects essentially for precision. Okay? This says that increasing the vaccination rate by 1 percentage point decreases PI mortality by about 0.73 per 100,000 residents during perfectly matched seasons and maximum expected influenza months. I told you it was an ugly interpretation. Right? If you look at the second row, I'll give you a nicer interpretation for this one. It's the same thing, but during 0 influenza months. So we expect that to be close to 0. And in fact, that's much closer to 0 and not statistically significant. All right? So here we see something similar also, negative and significant decrease for percentage of workers absent from illness, and essentially no effect when there's no influenza circulating. Yeah.
I just have a question about your illness measure. Is there any worry that you're picking up some sort of illness effect that's different from actually that's caused by influenza?
Oh, so absolutely these are defined as more broadly than just influenza. But anything that's not related to influenza shouldn't be, so in those measures, shouldn't be affected by the outcomes on the variables on the right-hand side. But absolutely that, a lot of the variation in the outcome measures here is not caused by influenza at all. Okay, so a nicer interpretation of this. This is what I call the expected annual benefit here, right? So this says that this is essentially just kind of a simple transformation of the number I had before, kind of taking average influenza activity across months and summing across months, multiplying by the average match rate. So this is kind of a number in expectation, right? Going into an influenza season, what would we expect to gain by increasing the vaccination rate by 1 percentage point? All right, so here 1 percentage point increasing the vaccination rate decreases PI mortality by about 0.25 per 100,000 population. All right, if you again scale that to the US population, it's about 800 deaths. Okay? And reduces hours absent by about 4,700 per 100,000 population. Again, scaled to the US population, it's about 15 million hours. Okay? Keep in mind that a 1 percentage point increase in the vaccination rate in the US population is over 3 million vaccines. All right, that's a big number of vaccines. Okay, so now thinking about who is most likely to be, or who is most affected by influenza, or who essentially benefits most from influenza vaccination, influenza vaccination. Remember again that I'm just defining vaccination here as all age vaccination. Okay? Here I'm going to look at all age vaccination and age-specific mortality. So if I look across the age distribution, what I see is I really only see anything for the 75 and older population. Okay, so they're really getting all the benefits of influenza vaccination. Now using the behavioral risk factor surveillance system, I can define vaccination rates as age-specific. And it's really useful in the BARFIS that the elderly population is oversampled, because that gives me actually a significant amount of variation in that population, so I can calculate vaccination rates for the 75 and older population and for the under 75 population. So what I'm going to do in the second panel here is in the same regression, I'm going to include all my interaction terms and everything for both the under 75 and the over 75 vaccination rate. All right? So essentially I'm estimating the effect of under 75 vaccination on over 75 mortality while still controlling for over 75 vaccination, all right, and vice versa. All right, and what I find is really this is operating all through under 75 vaccination. All right, and that if we think about the kind of model of the model I showed you earlier, right, that SIR model, that actually showed that most of the expected benefits are going to operate through an externality. And this wasn't explicitly included in that model, but we'd actually expect that to be especially true in the 75 and older population, because one of the main factors that contributes to an ineffective vaccine, I don't think I mentioned that there's variation in the effectiveness of the vaccine beyond the match rate. The match rate is just kind of an exogenously determined source of variation in that effectiveness of the vaccine. But in the 75 and older population, the vaccine is actually much less effective. So we'd expect the private benefits of vaccination to actually be relatively small. So what's interesting here is that, even though we really encourage vaccination in the elderly population, much of the mortality benefits of vaccination actually operate through the vaccination of other people. Yeah. Any questions? Yeah.
How correlated are the over 75 and under 75 vaccination rates?
They're certainly correlated. So the way I can identify this is basically there has to be variation across states in the gap between under 75 and over 75 vaccination. And there's actually a good amount of heterogeneity there, right? There's a good amount of variation in the gap between under 75 and over 75 vaccination. But they are very highly correlated, for sure. I mean, that's why, you know, standard errors are, I mean, I guess they don't blow up too much, but they're a little bit larger here. Okay, last slide on this part of the analysis. Thinking about monetary benefits here, all right? So I'm going to be thinking about trying to come up with a value per vaccination for the benefits of mortality and for work absences. So for mortality, I'm going to use a value statistical line, basically, okay? I'm going to use two versions of this. One is going to come from the EPA, and one is going to be come from the Ashenfelter and Greenstone paper, and that's kind of like a lower bound. Now, in both cases, these are going to be age-adjusted VSL numbers. This uses a model from a paper by Murphy and Topel that kind of gives a framework for calculating age-specific VSL figures. That way, I can calculate kind of age group-specific VSL figures. All right. For the 75 and older population, the age-adjusted VSL for the EPA is about $1 million. For Ashenfelter and Greenstone, it's about $250,000. I should note that the EPA does not allow you to actually use age-adjusted VSLs in their figures. So that would be about 8.8 million, the non-age-adjusted version, right? So the EPA uses 8.8 million for everybody. Controversial, but in both directions, I guess. But I think this is probably a more appropriate number than that. Okay. Then I'm going to use kind of this hypothetical national level policy, thinking about a 1 percentage point increase in the vaccination rate, right? That results in about 800 fewer deaths, all in the 75 and older population. So these are the VSL numbers I'm using, right? Only the 75 and older VSL numbers, all right? Here I have the total monetized value of that 1 percentage point increase in the vaccination rate. In the last column, I'm just dividing by 3.23 million, okay? The number of vaccinations that would be required to achieve this reduction in deaths. Right, so using the EPA figure, I find that each vaccine, in terms of social benefits, confers about $243 in terms of reduced mortality, and about $64 if I use the Ashenfelter and Greenstone estimate. Okay? Now, providing kind of monetary benefits for mortality, again, controversial, requires a lot of assumptions. I think much less restrictive assumptions are required for calculating the value of work. So here I'm just using the median hourly wage. A little bit easier, I find the value per vaccination is about $98 per vaccine, again in social benefits. Right.
So this is kind of assuming way heterogeneous effects among the kind of skill distribution of workers.
Yeah, yes.
Is there evidence for or against that?
Okay, so in the context of who benefits from.
Well, you have hours that are, you have this effect on hours missed of work, right? Mm-hmm. But the use of this $20.80 wage is going to depend on, how appropriate that is going to depend on where are these hours being missed in which workplace.
Yeah, I could.
And I wonder if there's anything we know about, say, education rates and vaccines, or the variation if it's kind of picking up a local effect on a particular type of workers, where there's there are other people who
might actually be a good thing to have Joe out of the office for a few days.
So yeah, right. Productivity on campus wide would increase. Yeah.
Right. So no, I'm making all those assumptions essentially. I think maybe what I could do to get at that a little bit is use wages in the CPS and just define. Well. Yeah. I'm not sure how to get at that. Basically, okay. I should think more about that though.
Where again is your missed hours coming from?
That's from the CPS.
And it's already aggregated at the, you have no distributional information about where those hours are coming from?
So what do you mean about what do you mean by distributional? So what part of the income distribution, or?
Yeah, exactly.
Yeah, so I could do something with like wages in the CPS there to get at that. I should try that.
Because it's certainly like just anecdotally, it seems like higher paying jobs are going to have a stronger externality benefit. Like if you're a construction worker working outside and you come unvaccinated and you get the flu, like versus somebody in a circulated air office, like white collar jobs, the social costs of infection are so much higher.
Yeah, I agree. Yeah, I should dive a little bit more into that.
Because it seems like that would do nothing but attenuate. Like it seems like using just purely aggregated numbers in a median wage would attenuate the social benefit.
Yeah, I think I might be able to not fully test that, but test that to some extent. So I should look. Okay. We're going to move on from the general analysis to the targeted analysis in 15 minutes. Okay? This is a little bit more straightforward though. So this is kind of a standard diff approach here. All right? A little bit of background before getting into the actual policies I'm going to implement, or I'm going to study. So in 2006, California passed a law that required health facilities to implement a few measures to protect against the infection of disease in those facilities. All right, so the first provision of this law is that health facilities must offer free influenza vaccination to all workers. All right, the second provision is that healthcare workers must sign a statement of declination if they decline to get a vaccine. Okay, so they just have to sign a piece of paper that says, I didn't want a vaccine, basically. All right, so what this is going to mean is when the vaccination mandates go into effect a few years later, baseline levels of vaccination are going to be relatively high. Third thing that's really nice is that this requires the hospitals report to the Department of Public Health on the percentage of healthcare workers vaccinated. That gives me data on a first stage when they implement these policies a little bit later on. And I will show you that indeed, vaccination rates on the baseline are relatively high. Right, about 70%, even without a mandate in place.
Is there any sort of variation across counties or facilities and sick leave policies?
Counties, I'm sure across facilities, absolutely. I don't know where I get that information. That's a good point, though. So I'm running out of time here. There's some really interesting stuff about the type of sick leave benefits that, I think it's interesting enough. So the type of sick leave versus vacation leave benefits that different types of workers get. So if you look at aggregated versus disaggregated sick leave, where aggregated sick leave means paid time off, so vacation time and sick leave is in the same pool. Like, guess which workers have the highest rates of aggregated sick leave, where you have the incentive to go to work sick to preserve your vacation time? It's nurses. They're exactly the people you don't want to have that. Of course, you also don't want like food service workers having that, but they don't have any benefits, so you don't have to worry about that. I have another paper on that. But anyways, that's an aside. But yeah, it's been kind of a dream of mine to write a paper on that, but I don't have the data. I'd like to get it if you know a guy. Okay, so what happens next? So in 2009, the H1N1 pandemic hit. In response to the pandemic, individual hospitals started adopting these vaccination mandates. Now, these mandates went into effect kind of mid-season, right? This is outside the normal influenza season, the H1N1 pandemic. So it's a little unclear the timing of these vaccination mandates relative to the timing of the epidemic, all right? So I want to kind of treat this year differently. In some specifications, I'm just going to drop these H1N1 years altogether, so that I'm estimating kind of the effect of these vaccination mandates on kind of seasonal influenza rather than pandemic influenza. All right. Beginning in 2011, 2012, counties started implementing these mandates rather than just individual healthcare facilities. Okay. So most of these county level mandates didn't just affect hospitals, but they affected all licensed healthcare facilities. There's a little bit more variation to that, but that's kind of the main story there. Right. So if it went into effect at the county level, this not only affects hospitals, but it affects long-term care facilities, etc. Okay. Now the important thing to note there, is that when I observe an outcome in the hospital, and that's going to be the unit of analysis here, it's not necessarily the case that that influenza diagnosis was actually contracted in the hospital. It could have been contracted outside of the hospital in another healthcare setting, or even in the community at large if healthcare workers act as kind of an important vector for disease at the county level. Okay. So here's what the variation looks like. The pink dots here are hospital level policies. The dark blue regions are county level policies that apply more broadly than to just hospitals. And there's a couple little light blue regions that are hospital only policies at the county level. You can see there's one here that actually turned into an all facility policy. And then there's one here up in a very sparsely populated county. Okay, so also note by the 2015-2016 season, 76% of hospitals in California were subject to one of these mandates. So more than likely, and in fact, San Diego, you guys are good, don't worry. Yeah, so these are increasingly widespread. More so in California than in other states in the country. And there's actually a couple state level policies at this point, but these are widespread. But when they started at the beginning of the sample, not so much. Okay, so a little bit about the data. Data on the timing of these mandates comes from the California Department of Public Health. It was kind of a process to collect this because the data they provided was not entirely accurate, so there's a lot of kind of hand-collected data, calling public health departments, county public health departments, and so on. First stage is also going to come from the California Department of Public Health. Over here you can see the distribution of hospital-level mandates, or sorry, hospital year vaccination rates. So with no mandate, you can see a pretty wide distribution of vaccination rates. Right? The mean is still pretty high though, around 70%. With a mandate, there's some variation. In fact, this hospital had like a 55% vaccination rate even with a mandate. But the mean is about 90% and a much tighter distribution. Right? So it kind of looks like these policies have some bite, but I'll show you that a little bit more, I think, convincingly in just a minute. The main outcome is going to come from the California Office of Statewide Health Planning and Development. This is going to be the universe of hospitalizations and emergency department visits in California. I'm going to be looking mostly at influenza-specific diagnoses. So unlike the mortality data, influenza is diagnosed quite regularly as a specific cause of admission. Okay? I can also look at pneumonia and influenza, but I'm going to lose a lot of power when I do that, rather than looking at their more specific outcome. All right? I'm going to look at a few other things. I'm not going to focus too much on these. They use a slightly different identification strategy, using a triple difference, also exploiting timing of the influenza epidemic. But I only have a few minutes left, so I'll probably just skip over it. Okay. So actually, one last thing to notice here. This is the distribution of annual admissions at the hospital level of influenza diagnoses. This is count data. So I'm going to be estimating this using a negative binomial model. All right, so the coefficients you're going to be looking at, you can interpret them as kind of differences in log points. Okay. What's the identification strategy? Standard diff and diff. We're going to skip over the second one here, and we're just going to look at this really straightforward one that's going to be estimated at the annual level. Okay, so it's just interested in this beta coefficient on this required variable that just says whether a hospital in year was subject to an influenza vaccination mandate with hospital and year fixed effects and some county level controls. Okay? Now, I think probably the most convincing evidence for the, again, parallel trends assumption here is going to come through these event studies. All right, so that's really how I'm going to present the results here. Okay? Okay, so this is the first stage, hospital worker vaccination rates. That's the outcome. What you can see is, leading up to the policy, no evidence of significant trends in differential trends in vaccination rates, but as soon as the policy goes into effect, pretty dramatic increase, right? About a 10 percentage point increase in hospital worker vaccination rates. So again, remember that these policies don't necessarily just affect hospital workers, but hospital workers is all I observe, right? These policies might have had a bigger effect for non-hospital workers because the baseline level of vaccination for hospital workers is higher than non-hospital workers, but enforcement might have been lower in these other facilities, so I don't want to generalize. So we're going to be kind of thinking about this 10 percentage point increase in vaccination rates. Okay, so the main outcomes are influenza-specific diagnoses at the hospital. So these are for inpatient hospital admissions. All right, this is what the event study looks like in the most kind of parsimonious version. There's no controls here, no county-specific trends, just hospital and year fixed effects. All right, what you can see is actually pretty strong evidence of increasing influenza admissions in hospitals that end up adopting these. Okay, but in this year of adoption, pretty dramatic decrease. If I add in, I think these are hospital-specific time trends and county-level covariates, you see this nice kind of shift here, right? So then very flat in the years before, and then kind of a dramatic decrease in the year of adoption that stays pretty flat. Okay. If I look at outpatient emergency department visits, well, if I do the kind of more parsimonious specification, it kind of looks like nothing's there. Maybe a little downtick in the year of. If I add in those trends and controls, it looks a little bit more apparent there's actually something going on in that first year at least, and then it kind of stays flat and negative afterwards. Okay, yeah.
So with the standard errors getting wider, kind of out away from the event, is part of that driven by you don't have a balanced panel
Exactly.
on the 2+ years and okay.
So I mean, you really want to pay attention to like these 3 right here, or like these 4, where you do have the biggest sample.
Right. So you're identifying then those kind of the late lags and the early leads off of a smaller subset than those that.
I've constructed this from -4 or earlier to 2 or later, so it's relatively balanced.
Okay.
But it's not perfectly balanced.
Gotcha.
Right? But there's not a dramatically different number here. So I could go even earlier. I get some kind of crazy stuff in the tails that's driven by like 1 or 2 hospitals.
Right.
But I think this kind of 4 earlier and then 2 or later approach that keeps it pretty balanced, I think is reasonable. But yeah, certainly that 2 or later has fewer observations than 1. Okay, 5 minutes. Okay, a couple more notes on this. So this is the same kind of results in tabular format here. So top panel is inpatient admissions, bottom panel is outpatient visits. Bunch of different specifications here. The first column is the most parsimonious, basically no controls, or no trends or controls or anything like that, covariates. The second one, I'm actually going to drop 1 year of the sample that had a bad match rate. Right? I don't have enough variation in the vaccine match to actually exploit that, but you would expect that if I drop a year with a bad match rate, that would have been attenuating my results, so the results should grow a little bit, and we find that, so it's a little bit reassuring. Okay? From there, I could add in county-specific trends, and that's when you see that kind of difference you saw in the event study where the results really come into play when you add those county-specific trends. All right, and here you see, this is my kind of preferred specification in column 4, about a 20% reduction for inpatient admissions, and an insignificant, but about an 8% reduction for outpatient emergency department visits. All right, I could also use hospital-specific trends, but the models don't always converge when I do that, so that's not my preferred specification.
So how many healthcare worker vaccinations would I require to see X% drop in those visits? I don't know what metric to use. 1%, 5%.
I'll show you in the conclusion. I have exactly that number, I think. Okay, so one more slide on this, and then I think I have a couple, nice things for people in the conclusion that I've been putting off. Okay, so one more kind of cool feature of the data that I can use to get at whether these infections were contracted in the hospital or not is this feature of the data that says for each diagnosis, was that diagnosis present at the time the person was admitted to the hospital? Right? So if the diagnosis was present at the time of admission, it's likely that influenza was diagnosed in a non-hospital setting, right? So maybe in your doctor's office, a long-term care facility, other healthcare facilities where these mandates went into place. But if the diagnosis was not present at the time of admission, that's much more likely to be hospital-acquired infection, right? So infection acquired in the hospital setting. All right. What I see if I look at not present on admission, so hospital-acquired infection, pretty dramatic decrease in this outcome, right? About a 43% reduction in hospital-acquired influenza when these mandates go into place, right? So if nothing else, I think it's a pretty impressive reduction that these mandates have in terms of hospital-acquired influenza.
I'm actually a little shocked that the diagnosis present on admission is so high.
As large. So this is almost the same. So almost all these diagnoses are present at the time of admission. So that could be for a few reasons.
Okay.
One, when people are filling out these forms, they just say present at the time of admission on everything, right? So part of it could come through that.
Okay.
But a lot of this could be. I mean, it is what it is. I mean, a lot of it could
Well, I mean,
be.
that's kind of the point of the paper, right? There's an externality benefit.
Right.
And,
I mean, no, I agree. It's
there
kind
should
of
be
it's
indirect
a little bit
channels.
surprisingly
So,
large.
yeah.
I mean, confidence interval, it could be as low as 5 or 6%, or something like that. But yeah, I agree, it's large.
Do you have a sense of what percentage of the population that hospital workers would typically be, and could you use variation in that across counties?
So I think I do have a sense to answer the question. I don't know if I could use. That's interesting. I should think about that. Yeah. Part of the problem with California is counties are so heterogeneous in California. So LA County versus Alpine County, where there's like 4,000 people or something, and 20 million people in LA County. So comparing anything across counties, there's so many things that are different. So I'm not sure, but I should probably wrap up. So the first question though is what percentage of the population healthcare workers? I think it's in the paper. It's a good percentage of the population. It's something like 3% of the population.
3%.
Something like that. Can't remember off the top of my head though. Okay, wrapping up. So what have I done in this paper? Estimating the marginal social benefits of influenza vaccination. All right, in part 1 of the paper, I estimate that each vaccine confers benefits of about $162. This is in terms of 75 and older mortality and in terms of work absences. Part 2 of the paper, I can show you this calculation, but I find that each vaccine confers benefits of about $131 just in terms of reduced healthcare costs. All right, now these outcomes, of course, are not comparable with each other, so you don't really want to make a comparison between these two numbers. But I can provide, I heard this term recently that I really like, an apples to pears comparison. Exactly apples to apples, but not apples to oranges, all right? So a little comparison between these two parts of the paper. All right, so what I'm going to do is ask how many vaccinations in a population of 100,000 people would be required to achieve a 1% reduction in either mortality or hospital admissions. Now I have to assume that influenza-related mortality and hospital admissions are going to be proportional to each other for this to be valid. A strong assumption, but I think not totally crazy. So for a 1% reduction in mortality, about 300 vaccines per 100,000 residents. And that's 300 general population vaccinations. For a 1% reduction in hospital admissions, about 35 healthcare worker vaccinations per 100,000 population. All right? So what this implies is that healthcare worker vaccinations are about 9 times more effective at reducing influenza as compared to vaccination in the general population, under some fairly strong assumptions. Now, to finally get back to your question, Zach, right? What are the marginal costs of vaccination? Yeah, so there's some estimates out there. It's a little bit hard to think about. These estimates from this paper indicate that somewhere between $15 and $37 in terms of just administration costs. All right, so what do we mean by administration costs? So that's just medicine, labor, overhead, anything that's really easily measurable, basically. All right, of course that misses the really significant and hard to measure stuff, like inconvenience costs and discomfort costs. Right? So while it's maybe not fair to compare these social benefits with these marginal costs, what I would say is that the benefits I'm estimating here are large enough that if we think about some recent evidence that shows ways to increase influenza vaccination at relatively low cost, it's still going to be likely that programs like those, so for example, one kind of program in a very specific population, basically showed this experiment that if you send emails to college students, one email saying, hey, go get vaccinated, and one email saying, hey, go get vaccinated and we'll give you $10, you can increase vaccination rates by about 10 percentage points. Right? Super low cost way of increasing vaccination rates. So certainly programs like that are going to be cost effective with benefits, externality, and social benefits like these. But making a direct comparison between the costs and benefits, a little bit more difficult. Okay, that's all.
Any last comments or questions? All right, great. Thank you so much for being here, Corey.